Well, thank you very much. To me, usability and workflow are friends that go together, and so it's nice to be able to go after that great discussion about usability. And I'm excited to tell you a little bit about my thoughts on workflow and documentation. So first of all, I always like when I'm talking about workflow to start from the position of kind of defining what I'm talking about, because workflow is one of those terms that has really lost its meaning over the years and has multiple different definitions. So the way that I think about workflow, although I love a good flow chart, is really much more of a socio-technical model and a little bit more than just a flow chart of steps that people do in their work. And so I usually start from this perspective of the workflow elements framework, which we developed based on a literature review. And so the workflow elements framework has these two components, a specific component and a pervasive component. On the specific component, we have like the actual work that's happening, right? The actors, people performing actions that produce outcomes, artifacts that enable the performance of those actions, and characteristics that describe the actions. But then we have the whole pervasive level of where that work is actually happening. So we've got the context part of, what is the organization? How do these pieces fit together? But we also have temporality, so the timing of actions and how they relate to each other in terms of scheduling and coordination. And then aggregation, as you add these different actions together, as you combine actors together, what happens at that point? And so that's really the socio-technical perspective that I have on workflow. And I was like, when I'm thinking about a new topic, like documentation, to kind of break it down to the most fundamental. So if we take documentation and put it in this framework, at its most fundamental, we have a healthcare team member, which can include patients and family members, performing the action of documenting patient data in the EHR, producing data available to the entire healthcare team for use. How nice and simple this is when we look at it, except we know that's not really true, right? It's much more complex. So some of the artifacts that we have that enable documentation are the electronic health record, but we also have paper notes and paper forms and little pieces of Post-it notes that have a note scribbled on them. We have the things that patients bring in, whether it's notes or materials or devices like a handheld glucose meter. And so these are all tools that we can use to get information into the EHR. And then when we start describing the work of documentation, sometimes we know that it's visible, it's happening like in the exam room with the patient sitting right there and the physician typing a note in. But we know there's a lot that's also invisible behind the scenes, including finishing a note in your home at 10 o'clock at night. And then also just to highlight another aspect, another characteristic of documentation, that sometimes it's very rigid. There's a form, there's click boxes, you have to do these steps in a certain way. And sometimes it's really flexible when you have like a free text note. So when we add in some of those pervasive elements to documentation, we have this idea of temporality, all of the other timing things that are happening as you're trying frantically to do your documentation, as well as the context where your documentation is happening. So one thing I always like to talk about is in terms of physical space, how an exam room is set up, where the computer is positioned. It can really fundamentally change the process of documentation and how people feel about doing documentation while in the room with a patient. And then finally, this aggregation piece, like what are the actors that are waiting on these documentation tasks to be completed? Who else is contributing to the documentation? And then what other tasks downstream are waiting on this information to be entered, this data to be entered into the electronic health record? So I also like to ask questions when I think about tasks, and I often break it down according to this really simple who, why, what, when, where, and how. And I found when I typed these up earlier this week that I was like, wow, that's kind of complicated. Let me look at a couple of examples. So let's dive into a couple of workflow related questions. First, this question of when and where. I'm going to share a couple of representative quotes from studies that I've done over the years, but just know that these are representative quotes. and there's a whole kind of body of data behind these kinds of comments. So first, from a nurse practitioner who was describing why her process of not doing documentation while in the room with the patient, she said, "I just don't do that. I have to do it in between patients. That's what I do during my lunch break. Is what I do at the end of the day. It's why I'm here until 6:30 or 7 at night." And you can kind of just envision like the frustration when someone tells you something like this and how they're feeling about it. But this is something I've heard many times over the years in different studies as we're collecting data. So where people are documenting, sometimes it's in the exam room with the patient, sometimes it's in their office, sometimes it's at home, sometimes it's a combination of all of these three. Sometimes it's during the patient-visitor encounter. I mean, I think that would be, to me, as a design-oriented person, the ideal time. But oftentimes, even if you start a note while you're with a patient, there's work that happens afterwards that needs to be done. There's, in fact, a term that I'm sure everyone on this call is familiar with, the idea of pajama time, the documentation that happens after a physician, for example, goes home and they're, put their kids to bed and then they still have to finish their notes at night. And then the other thing I wanted to highlight is that there are many downstream effects of documentation workflow variability. So the classic example that I always think of is the after visit summary. And the idea that, when the patient left the exam room, they should get their after visit summary. But really, if the documentation isn't happening at that point, when is that actually finished, that process? The next question I want to talk about was kind of the question of who is doing the documentation, because that's another important aspect of workflow. And just a couple of quotes in this that a physician in an emergency department said, "As this computer stuff progresses, we do less and less patient care and more computer games." And that's not, as a computer-oriented person, that's not something you want people to be saying about the tools you're working on. But also the information that's in the electronic health record of a nurse talking about a problem list and trust issues, that I don't trust it because anybody can edit that screen. So who is doing the work? One thing that we've noted over the years, particularly kind of an inflection point at meaningful use, is a shift in the narrative, and particularly about how physicians talk about documentation, where before that, documentation was just part of something that they did as their clinical work. But at a certain point, the narrative shifted to documentation being basically clerical work that shouldn't be part of the clinical work. Then as well, this question of issues relating to trust when the source of documented information is not totally clear, when you can't easily trace the full pathway for that. And then a good thing on the horizon, I think, but something that does complicate workflow, the increasing roles for patients and families in documentation. So patients perhaps entering their own data that then gets integrated into the electronic health record. And then finally, getting down to the root question for me for workflow is the why. Like, why are we doing this documentation? And this was a physician talking about new technology features, and he said, "I'd be interested in anything that improves patient safety. At the same time, I'm just very cognizant of anything that would involve new responsibilities by the physician. If you can show that it saves time, then I think it's a different issue." And again, on this time point from a nurse practitioner, I just spend more and more time here. Every time they roll out something wonderful, it just takes more of my time.
And Kim, you have 1 minute left.
Thanks, Patty.
All right.
And it really comes down to this idea of, if we go back to this kind of this flow, this very simple flow of what's happening, at the end, our outcome is data available to the entire healthcare team for use. But we know that physicians, nurses, everyone in the healthcare team knows that there are many different reasons, many different outcomes of putting the information into the EHR. And some of these are things that are really pain points, like the idea of, I'm entering this data for billing purposes, which is something we hear over and over again in various studies. And then just finally to wrap up, actually tying back to something that Zach mentioned about usefulness and really the heart of what we're doing here. The idea from Barbara Minerell talking about usefulness as a value that users experience. They experience it when they know their work is better for having interacted with an application. And I think that's where we really want to be with documentation and electronic health records and putting information into the system. But I really have to question if we're there yet, based on what we've seen across multiple studies. Okay, and with that, I'll give it back to you, Patty.